Okay, imagine the unthinkable happens. We're talking a massive earthquake, a horrific multi-vehicle pileup, or maybe an explosion. You're a first responder on the scene, and there are dozens, maybe hundreds of victims. How do you decide who gets care first? I mean, who lives and who dies when your resources are completely overwhelmed? It's not guesswork, guys. It's a highly calculated, brutal, but absolutely vital science. Today, we're diving into this explainer to explore the extreme edges of emergency medicine. So, here's our roadmap for survival. We're going to cover the START triage protocol, blast physics and kinetic impacts, crush syndrome and rhabdomyolysis, deadly soft tissue infections, and finally, the trimodal distribution of death. Let's get right to it. Section 1. The START triage protocol, sorting the chaos. Right, so when medical facilities are completely overwhelmed, normal emergency protocols go straight out the window. The mission instantly shifts to one operational goal: maximizing survival across the entire population. Let's look at this first question. When we hear the word triage, what does it actually mean in a medical context? Are we talking surgical care at the scene, dividing by age, evacuation, providing food and shelter, or sorting and classifying based on priority? Well, the correct answer is sorting based on priority. It's a highly structured protocol. In the field, you have to do this blisteringly fast using the START algorithm that stands for simple triage and rapid treatment. A field responder gets literally 60 seconds per patient to evaluate three basic things: respirations, perfusion, and mental status, the RPM check. Now, what's really interesting here is the brutal logic behind these color-coded tags. It relies entirely on salvageability. Red means immediate priority. Think life-threatening injuries like a tension pneumothorax or massive bleeding. Basically, they have a high chance of survival if you intervene right now. Yellow is urgent. Serious stuff, like compound fractures, but their vitals are stable enough to hold off for a brief window. Green is your walking wounded. They have minor injuries and can physically walk themselves out of the impact zone. And black. This represents the expectant or deceased. These are catastrophic injuries like severe brain damage that are just incompatible with life under severe resource constraints. Let's apply this. Say a rescue team arrives at a massive crash, a tractor trailer versus a small car. A victim has multiple uncontained wounds, but his vitals initially seem okay. How do you triage him? Red tag. Immediately. Why? Because of something called mechanism triage bias. High-velocity, massive energy collisions carry a huge risk of a static trap. Hidden internal bleeding could be masking his shock. His body's compensating right now, but he could undergo rapid physiological failure at any second. High kinetic energy transfer automatically demands a red tag. Section 2. Blast physics and kinetic impacts, the invisible forces. Speaking of massive energy transfer, let's step into the terrifying invisible physics of a blast zone. An explosion attacks you in phases. First comes the primary blast injury. This is an invisible wall of overpressure traveling faster than the speed of sound. It violently disrupts air fluid interfaces and hollow organs, like shredding your lungs or eardrums. But then comes the tertiary injury. This is caused by the physical blast wind that follows the pressure wave. It acts as a secondary destructive force that can literally pick someone up and throw them into a solid structure, causing massive crush trauma. So if we look at this next question, after a bomb blast, why do many people close to the epicenter die immediately? Is it from the sound wave, flying shrapnel, or severe blunt force injury? While the blast wave definitely ruins hollow organs, the immediate, inescapable killer is severe blunt force injury from that massive kinetic impact. For the folks slightly further away who survive that initial concussive hit, primary blast lung injury becomes the biggest fatal threat, sometimes causing deadly air bubbles, air embolisms, to travel straight to the heart or brain. Section 3. Crush syndrome and rhabdomyolysis, the hidden cellular killers. But what happens when the dust settles and victims are left pinned beneath collapsed buildings? We shift from sudden physical impacts to insidious, hidden cellular threats. Imagine a 39-year-old earthquake victim who was pinned under debris. He's rescued, he's in the hospital, but on day 2, his urine output drops dangerously low. What's the next step? Do you wait and watch, administer blood, or start mannitol alkaline diuresis? The answer is mannitol alkaline diuresis. This is crush syndrome. When a heavy object crushes skeletal muscle, the cells break open and dump massive quantities of a protein called myoglobin into the bloodstream. When that myoglobin hits the acidic environment of the kidneys, it clumps up and directly poisons them. Let's see how this builds into a strict, life-saving protocol. Step 1 actually happens before the rubble is even lifted. Responders have to pump high-rate intravenous saline into the patient to dilute that incoming surge of myoglobin. Step 2 is alkalinization. You add sodium bicarbonate to the fluids to raise the urine pH above 6.5, which actually stops the myoglobin from clumping. And step 3 is using a diuretic like mannitol to flush the kidneys out. But, and this is absolutely crucial, you only do this after the patient is fully hydrated, otherwise you'll just make the kidney failure worse. Time is the ultimate enemy here. If a patient is trapped for 12 hours with a crushed, pulseless leg, what do? Observe, perform a fasciotomy, or amputate? If doctors catch this early, within 6 to 8 hours, they can slice open the fascial compartments in a procedure called a fasciotomy to relieve pressure and save the limb. But at 12 hours, that muscle is dead. If you do a fasciotomy now, you open the floodgates for massive amounts of toxic myoglobin and potassium to rush back into the heart, causing lethal cardiovascular collapse. In this late presentation, immediate amputation is mandatory. You literally have to sacrifice the limb to save the life. Section 4. Deadly soft tissue infections, the microscopic battle. For patients who survive the initial trauma and the crush injuries, an entirely new microscopic battle begins. I'm talking about the threat of aggressive soft tissue infections like necrotizing fasciitis, flesh-eating disease. This comes in two main forms: monomicrobial, which is usually driven by a single vicious bug like group A strep, and polymicrobial, a highly virulent, synergistic mix of multiple types of bacteria working together to destroy the deep fascial planes beneath the skin. The absolute hallmark sign here is intense, excruciating pain that seems way out of proportion to what the skin actually looks like early on. The only way to stop it is an absolute mandate for urgent, radical surgical debridement. You have to cut away the dead tissue until you reach healthy, bleeding margins. Another horrific infection in deep, traumatic wounds is gas gangrene. Which of the following is true about it? Is it driven by endotoxins? Does it only respond to hyperbaric oxygen therapy? The critical truth here is that it primarily involves the muscular compartment. It's caused by Clostridium bacteria, which thrive in deep, oxygen-starved wounds. These bacteria literally ferment the glucose and glycogen inside the patient's muscles, producing a tissue-splitting gas that actually crackles beneath the skin. And this brilliantly illustrates why it's so lethal. These bacteria don't just eat tissue. They deploy targeted chemical weapons called exotoxins. Alpha toxin systematically blows up red and white blood cells. Kappa toxin literally melts blood vessels. Phi toxin acts as a direct depressant on the heart. To fight this incredibly rapid destruction, doctors have to administer massive doses of triple intravenous antibiotics alongside immediate surgical removal of the infected muscle. Section 5. Trimodal distribution of death, the ticking clock. So we've looked at the chaos of the scene, the blasts, the crush injuries, and the infections. Now let's zoom all the way out to the macro-level statistics that dictate why emergency medicine protocols are designed this way. Notice how mortality predictably peaks in 3 distinct waves. The immediate peak happens within seconds to minutes. The early peak happens within a few hours, often called the golden hour. And the late peak happens days or even weeks after the initial event. Breaking those peaks down, 50% of all trauma deaths happen in that immediate peak. These are catastrophic, unsalvageable injuries. 30% die in the early peak, primarily from airway failure or massive blood loss. But I want you to focus on this 20% slice, the late peak. These deaths, happening days or weeks later, are almost entirely driven by multi-organ failure and systemic sepsis. And here is the real tragedy. These late deaths are heavily influenced by inadequate or delayed early resuscitation. If you miss a patient in the golden hour, they slip right into that 20% group later. That is exactly why emergency responders use physiological scoring tools. You have to catch those patients before they fall into the late peak. The revised trauma score is one of these crucial tools. So, which of these indicators is included in it? Heart rate, pupil dilation, or systolic blood pressure? It's systolic blood pressure. Why? Because blood pressure, along with your respiratory rate and your mental status, gives doctors a near-instant snapshot of whether you are bleeding out or failing to oxygenate your tissues. So, the crucial point is how these 3 simple variables, the Glasgow Coma Scale, systolic blood pressure, and respiratory rate, dictate the ultimate fate of mass casualty victims. By tallying these scores, medical personnel know who needs the operating room this exact second to survive that early peak golden hour and who is stable enough to wait. It completely removes human bias and ensures that limited resources are directed strictly by physiological salvageability. Which brings us full circle to where we started. In the horrifying context of a mass casualty event, the standard rules of medicine have to be suspended. It's not about first come, first served. It is about maximizing survival across the entire population to achieve the greatest good for the greatest number. It's a harsh philosophical truth, but as we've seen from the physics, down to the cells, and out to the statistics, it is the only science that allows us to bring order to the chaos and pull as many lives as possible back from the brink. It leaves us with a pretty heavy question to ponder. How would you handle the immense logistical and clinical burden of deciding how these vital, limited resources are allocated when every single second counts?